Session 2 is about understanding what motivates primary care physicians and getting an overview of our employment market from what it looks like working for large health systems to picking up temporary shifts as locums physicians to what it looks like to put up your own shingle as an independent doc. The invisible hand that influences our work is the doctor patient relationship. It's often the main driver of motivation for why physicians get up in the morning. We explore this in detail by sharing examples of the kinds of patient personas we interact with on a daily basis.
Perhaps the biggest driving motivation is finances. So, along with getting two letters after our name, med school also gifts us with a ton of debt. On average, med students graduate with $251,000 worth of debt. And of course, keep in mind, this comes with interest. Most government loans, which we all get, have about a 5 to 6% interest rate. The other thing to know about finances is on a spectrum of doctors, primary care specialties tend to get paid the least. Again, that's usually pediatrics, internal medicine, and family medicine. To give you an idea of how much less, think about dermatology. So, family medicine is a 3 year residency. Average coming out is in the low to mid 200,000s. And dermatology is a 4 year residency, and they come out and make about 400,000. The other thing is during residency, everybody gets paid the same fixed salary, about 50 to 60K, which doesn't really help with the debt situation because you're making minimum payments while essentially paying for cost of living. Coming out, most residents will be looking for a job that dangles the best carrot in front of them. There are different ways that they can be incentivized. So, one big common one is the bonus. So there are a bunch of different types of bonuses. A sign-on bonus for simply choosing the company to sign on with or hospital system. Moving bonuses if you need to relocate, and other random bonuses that people decide to give. In the value-based system, of course, there's the end of the year, I didn't send my patient to the ER bonus. Most starting jobs will be salaried because when you're a new PCP in an area, you don't really have a patient base, so it doesn't make sense to do productivity because people have to know who you are, establish with you. And then later on, usually in a 2 year period, it becomes productivity. So all these contracts that people sign will have some sort of starting bonus and then talk about productivity after a certain cutoff point. And then the final thing is making partners. So some people will choose to make less money in the first couple of years with the promise of becoming partner, usually in a private practice or a multi-specialty group where the potential upside is much higher, where they can partake in the overall profits of the practice. So who's dangling these carrots? There are various players in the employment market. First and biggest is the hospital system. Hospital systems generally can give much bigger bonuses and often pay a lot in terms of the first couple of years' salary. That being said, they are also notorious for dropping significantly under the productivity model, where it's pretty cush for the first 2 years, and then all of a sudden you find yourself grinding and making less than you did before. A special mention under hospital systems would be systems or value-based care systems like Oak Street or ChenMed, where you are bonus based on how much overall cost savings you present, though this is fairly uncommon still right now. In the independent group, they don't offer as many bonuses, though many will offer some, and the pay tends to be lower, but they offer the promise of partnership. People who are a little more entrepreneurial but don't want to start their own thing will frequently join these partnership groups. Of course, there's always drama involved where I've talked to several doctors who join independent groups or multi-specialty groups, and when it's time to make partner for some reason or another, the current partners delay them or deny them, and it gets into a whole mess. Though I will say those are generally the minority. And then locums for people who want to move around more, generally younger, though anybody can do this. You're basically an independent contractor doctor. So just like any other independent versus employee situation, you can get higher overall pay in straight cash, but you get fewer benefits because you're not an employee, and therefore the hospital system or group is not required to provide you any benefits. And of course, the payoff is you get a ton of flexibility in terms of hours and where you want to be. And then shift work, kind of similar to locums, but what we're talking about in terms of shift work here is more so you're working for a urgent care or some sort of virtual company where you're an employee doing shift work. Most primary care offices are your standard 9 to 5, but there are opportunities if you do a primary care specialty to go do some sort of shift work. And pretty much all of these are productivity based. There's generally some sort of base pay that's fairly low. And then when you essentially grind through people and churn through the patients, you get paid more based on how many people you see. And of course, the final option in terms of employment is to work for yourself. That number has been dropping pretty steeply. In 2020, the American Medical Association reported that 44% of doctors overall, and this is any specialty, were self employed, which is pretty low. I think the number dropped below 50% around 2017. And the reason is because there's more challenges than opportunities in this space. Earlier, I talked about the many carrots that can be dangled in front of these debt-ridden residents looking for a job. And part of hospital system or any other type of employment is what we call golden handcuffs, where we're pretty much tied to something that we don't necessarily want to do, but we have to because the money is good and we need the money. So the challenges to self-employment, of course, involve not just the cost of starting a business, but also the opportunity cost of doing so. So instead of immediately making a salary plus bonus and sign on and all that stuff, you're spending money on the business and then you're not getting the salary that you otherwise would get. Also, low reimbursement rates, which really apply to fee for service space. This is why companies like Privia exist, because as an independent doctor, the solo doc who's trying to negotiate with the insurance companies, the rates that you're going to get are pretty low and unsustainable. When you start forming a multi physician practice, then you can go as a group. And one of the brilliant things about Privia is even though they are independent practices using Privia, Privia will negotiate with carriers as a whole, as if every independent Privia practice was a single group. The other big thing is most doctors don't have any sort of business training. They have no idea. We come out with about a decade's worth of straight just science and critical thinking where we just learn how to solve medical problems. We're very highly trained, highly debt ridden, without a skill set that has a lateral movement. Like business, you can, one day open up a health tech company, next day run a restaurant. It's the same kind of underlying structure. But when you train as a doctor, you learn how to do medicine and it doesn't really translate. That being said, Dr. Bricker, Eric Bricker of A Healthcare Z, says that doctors are great autodidacts. We're good at teaching ourselves things. And so that's why you do see some very entrepreneurial doctors come out and just learn business things even without the formal training. And so in the self employment space, you generally see two flavors of self employment. It's either a direct primary care practice where the overhead is super low and not dependent on insurance reimbursement or negotiations. You're in a group like Privia, which has all the benefits mentioned earlier, or you're in a weird cash-based niche, the most common ones being functional medicine and aesthetics. So like Botox and lip fillers and that kind of stuff, which yes, anybody can do. There's no formal accreditation or anything. So those are the more financial based incentives. The other big motivator in terms of how and why doctors do what they do is the doctor patient relationship. How patients relate to us and how we relate to patients actually plays a pretty big role in terms of how we practice medicine. And to give you an idea of some of the patients that we see on any given day, just like we had doctor archetypes, here are some patient archetypes. The first one is hand on handle. These are the patients who you go through the entire encounter, everything's good, you finished on time, you get to the door and you touch it, and all of a sudden they say, "Oh, by the way." And frequently with this archetype, these are the patients who their main chief complaint is what they tell you with your hand on the handle. Sometimes it's because it's something embarrassing like erectile dysfunction, or for some reason they just forgot. But you complete the encounter, you touch the handle, they go, "Oh yeah, by the way," thinking that you'll just give them time to do a whole other visit, which is generally untenable. Then you have your stoic who doesn't say anything. In medicine, farmers are usually the most notorious for this. You go in the room and you say, "Hey, what brings you in today?" And they go, "My wife made me come in," or "My girlfriend made me come in." And yes, it's frequently a male. These are the people where you have to try really hard to get them to tell you what's going on and to even potentially get them to acknowledge that they understand what you told them and the care plan, because a lot of times they'll just not do what you ask them to do. On the flip side of that are the dramatic patients. And this actually makes life harder for various different people, because these patients, by being louder or talking more effusively about their pain or chronic issue, it sets a lot of doctors' threshold for what's serious much higher. You hear on the news about how some patients are crying, yelling in pain, and the doctor didn't take them seriously. That's because for every out of 100 dramatic patients, maybe one person actually has something serious, and it's very hard to tell the difference. And of course, you get a lethal combination when you have the dismissive archetype doctor with a dramatic archetype of patient. Then you have the storyteller. These people not only talk a lot, they like to give little details that have very little relevance. In other words, their history tends to be pretty low yield overall. So, for example, crushing chest pain, a concerning chief complaint for a heart attack. You come into a room, you say, "Hey, Miss Johnson, what brings you in today?" "Oh, yesterday I was grocery shopping and the blueberries were on sale and..." "No, no. What brings you in today? Your chart says you have chest pain." "Oh, yeah, I was getting to that. Anyway, so at the register, the clerk was really nice. And so I wanted to tip them, but of course you don't tip clerks. That doesn't make any sense." And so on and so forth. So it's usually pretty hard to get pertinent information. You really have to direct the conversation. Then there's the note taker, comes with a journal, a book, and they will show you everything that they've been doing that you talked about last time. They will actively take notes while you're talking to them, usually very, very organized and very on top of everything. You don't have to tell these patients twice, and they're incredibly proactive. On the flip side of that is the bag carrier. These are the patients that come in with usually some sort of plastic grocery bag with all their pill bottles in it. And frequently you'll see duplicates or expired medicines. And they say, "Here, doc, here are all the meds you've prescribed me." And you say, "Are you taking all of these?" And they go, "Yeah, these are all my medicines." And again, there are duplicates and expired meds. So as opposed to the note taker, generally pretty disorganized, need a lot more education and guidance. And actually, sometimes having them just keep bringing their medicines to you so that you can throw away old or duplicate bottles can be pretty helpful. Then there's the Riddler, where they'll come in and not really tell you what's going on, but no matter how much you try, they just keep beating around the bush, and you really have to dig. The open-ended questions don't really work well, so you ask more directed questions, and it's just a song and a dance. The contrarian is a patient type that comes in and most doctors aren't really sure why these patients come in. They'll come pretty regularly and they'll engage with you, but only to disagree. You'll say, "Hey, your cholesterol's high. You should be on a statin." "Nah, I'm good." "Okay, your blood pressure's high. Have you considered a blood pressure medicine?" "Nah, I'm good." Or you say, "Hey, maybe some more diet and exercise in your life." "Sure, I'll think about it." And they come to you, but you're not sure why, and they just sometimes eventually they'll follow the treatment plan, but not always. Then there's the researcher. So there's two different types of researchers. One, of course, better than the other. The first researcher is the educated researcher, the one who really cares about their health, really cares about scientific rigor, and a lot of times they'll know more than I do on the topic. They come in with the newest paper and they'll say, "What do you think about this?" Or actually, one of my patients is similar with chronic kidney disease. We were talking about one of his lab values, and he's like, "Well, actually, according to this society, if you do the calculation this way, the number is actually this." And I was like, "What are you talking about?" And I looked it up, did the calculation myself, and sure enough, he was right. So the first type of researcher really keeps us on our toes, and they're actually a great resource to keep us up to date. The other type of researcher, of course, is the researcher who only chooses to research alternative papers and sources where they come in and they say, "This news report said this," or "I heard this on TV and they said this," or "This fringe group said this or the other." And these people take a little more time because you have to first acknowledge what they're bringing in, look through the data, and explain to them why that is wrong. One of the examples in my practice is somebody showed me this lecture by this MD, actually, this doctor who was talking about how cholesterol is actually good for you and how you actually live longer with higher cholesterol. Luckily, I have an interest in lipidology, so I went through the YouTube video and basically tore it apart line by line, and the patient found it really helpful. Um, but anyways, these researchers just take a little more time, and they also keep you on your toes, but in a different way. And then, of course, finally is the patient who is seeking validation. And this one is always really tough. And I feel like, I don't know if it's just me, but it seems like there's more and more of these patients nowadays where they come to you with a problem and they just want a diagnosis. For example, one of the more common ones in an urgent care setting is a cold. So many people come in with a day's worth of sore throat or sniffles, and you tell them it's a virus, and they're just mad at you. They're upset. You tell them, "Go home, drink some water, get some sleep. It'll go away in 4 or 5 days." And they'll be mad because they wanted you to say, "Oh, you have some sort of illness that requires some treatment. Here's an antibiotic. Have a nice day." And some chronic conditions are that way as well. People who don't sleep enough, exercise enough, or eat poorly will come in hoping you diagnose them with like Ehlers-Danlos or even chronic fatigue syndrome. For some reason, people are happy with chronic fatigue syndrome. So knowing these archetypes and seeing all these different types of people, why it matters is because one of the big metrics in primary care is patient satisfaction. How much does your patient like you? And we kind of have to keep all these archetypes in mind when we're engaging patients so that we can best communicate with them to effectively deliver care. Sometimes it can be hard, especially when what patients want and what patients need don't line up, which is surprisingly frequently. When I was a first year resident, just starting out, I did everything by the book. I walked in, talked about guidelines, this, that, and the other. Patient satisfaction scores, terrible. Towards the end of residency, I started just catering more towards the patient and having more of an attitude of, "Okay, what do you want today? What did you come in for?" And scores went up. I was a little looser on the guidelines, but because I gave the patients what they wanted, they were happier. To the earlier example about the urgent care giving out antibiotics, the patient doesn't need antibiotics, but they want it. And because of that, they'll frequently get it. And I think that's something that people don't appreciate too much that happens behind closed doors in a lot of primary care offices is there's a lot of things that get prescribed or ordered not due to medical necessity, but because of patient demand. And that gets us into liability. The most common causes of medical litigation is misdiagnosis. So if a patient says, I think I have this, I need a head CT. Odds are you're probably going to do it because even if the chances of a patient having something that can be found in a head CT is super low, if they've asked for it and that 0.1% chance they have it and you didn't do it because the probability and the science said otherwise, and then we start practicing what's called CYA or cover your ass medicine. The other way to spread liability is to refer. So there are certain criteria to refer patients, but one of the unspoken ones essentially is to CYA. If the patient's complaining of chronic headaches, the workup's been done, you don't know what's going on, or it hasn't been done, you don't really feel like ordering it, you can always refer them out to, say, neurology. And now it's neurology's fault if they don't order the head imaging. And then, of course, the final big motivator for our decisions is metrics. Probably one of the most reviled things in primary care. Some examples, Medicare had the MIPS and macro program, which basically said, these are the certain things you have to hit. If you don't hit these criteria, then you will make less money. So, for example, one common metric is the hemoglobin A1C, which is a 3-month average for how high a diabetic sugar is. And any primary care doctor can tell you, no matter how good you are at medication management, counseling, and doing close follow-ups, there's very little you can do once a patient is out of your office. If you put them on the optimal med management, do all the screening you can, counsel them to eat their vegetables and do exercise, and then they leave your office and go get a large frosty and then watch a marathon of the latest Netflix show, and then their A1C is much higher the next quarter, that's not your fault, but you lose money because of it. The new value-based care arrangements, of course, are reducing risk, so keeping people out of the ER, which is interesting for all the risk-bearing ones, because again, a lot of the times you don't have control over it. And then the other big metric is speed. So for people who are productivity based, which most systems are in one way or another, especially in the shift work paradigm, then the faster you go, the more patients you see, the more you get paid. And keep in mind, again, with the high debt load and being already the lowest paid group of specialties amongst doctors, these metrics play a huge role in how primary care doctors perform because the only way you can really augment your pay or sometimes even get to median pay is to make sure you're hitting all the metrics in the way that the payers want you to hit them.
To summarize, we just learned about primary care physician motivations, their employment landscape, and we took a look at different kinds of patient personas and average primary care doctor experiences, and reviewed additional factors such as patient satisfaction, reporting metrics, and liability that mold our behavior. This concludes session 2.